I think we'll make a start now. Thank you all very much for joining today at the Breast Disease Education webinar organised by Thames Valley Cancer Alliance and the Surrey and Sussex Cancer Alliance. This is a joint venture to try and make sure that we ensure that everyone understands the issue of breast disease, specifically also relating to referrals and to disease management, and to engage with in terms of referral. Just a bit of housekeeping. Please keep yourself on mute and turn off your camera unless you're a speaker, in which case you'll have to unmute yourself. Please use the raising and lowering of your hand if you want to ask a question. And of course, please put comments and questions in the chat box. I think everyone's used to Teams in this brave new world. Next slide, please. Today's agenda is a very packed agenda. We have referrals data to be discussed during the COVID-19 pandemic. We have the importance of breast examination and NICE guidance. We'll cover aspects of gynecomastia, breast pain, and we'll also be looking at a pathway which has made quite a difference in Surrey and Sussex. We will, of course, end with a panel discussion and a question and answer session, but that is time limited in a sense. But do please put in comments and chat in the chat box, please. Next slide, please. We're today really grateful to a variety of really eminent speakers, actually. We've got primary care GPs and clinicians, we've got specialist nurses, and we've got consultants who've got a lot of experience in this area. Next slide, please. So really, I mean, I think one of the first starting points is the anxiety that breast disease and breast symptoms cause. Lumps is the classic one, and these are some comments from a patient of mine. I found a lump in my breast and I'm terrified. I can't cope. I'm shaking and crying. My kids are getting upset and I can't bring myself to ring the doctor. My husband is getting annoyed. I can't rationalize this at all. So there is a huge anxiety about breast disease. Here, the next comment is about a relative who's had cysts in a breast. And this is an example of maybe what the patient thinks that it could be. Finally, is the bit that we're all quite anxious about in terms of primary care workload. I rang my surgery. They're constantly engaged. It's driving me crazy. When do I get through? When I do get through, it's at least a week await. I just feel I can't wait 3 or 4 weeks for answers, yet I know I'm going to have to. I just don't feel mentally strong enough. So these are really comments from a patient. Next slide, please. So really, and this is not a comprehensive list at all. This is just a bullet point list that I came across, which are the patient aspects in relation to breast symptoms. A lot of patients feel that this is what is expected, what happens. It probably will go away, and serious illness doesn't happen to me. Patients frequently say, I don't want to waste anyone's time, and so I won't get an appointment or seek advice. But underlying really is the fear of any serious diagnoses, any examination worries about whether it hurts or whether it's going to be the right person examining them. They're worried about investigations, what type of investigations they're going to have. Will they hurt? Are they going to be scans? Is it going to be a biopsy? They're obviously worried about operations and the impact of operations on their life, and certainly the body image effects of treatments. Culturally, and certainly COVID has brought to the fore a lot of the BAME aspects that we need to be aware of. Certainly patients may have lack of knowledge on when to seek advice. There may be a bit of shame attached to their illness. They may feel that they're defective in some way and there's a problem which they don't want to share with anyone else in the family or friends. And there is also a feeling that this is meant to be. I'm going to get an illness, so I've got it now. I've just got to live with it. So these are some of the aspects which I think as clinicians we all need to be very aware of. Next slide, please. And now, obviously, during the COVID times in the past year, there has been quite a change in the referral and quite a drop. So we thought we'd share a couple of slides with you about what has actually happened in terms of referrals. Next slide, please. So in terms of the Thames Valley Cancer Alliance picture, clearly there was a drop right at the beginning of the pandemic, and referrals dropped below the baseline as shown by this graph. However, from mid-June, the breast referral numbers have recovered and there's been a stable trend in line with previous years. There was a campaign in October 2020 when the 2-week weight GP referral pathway saw a significant rise above the baseline. And in fact, really, there is a difference now, which equates to an 11% increase in referrals. This may relate to a bit of health anxiety, of course, which is what's fueled it, or maybe delayed presentations that patients are coming forward. So there is definitely an increase in the referrals in the breast pathway. Next slide, please. I'm going to introduce to you Dr. Alex Norman, who is the cancer lead, who's going to talk a little bit about the Surrey Cancer Alliance picture. Next slide, please. Over to you, Alex.
Thank you. That's great. Thank you very much, Anand. Just to really reflect what Anand said about the Thames Valley picture, we've experienced exactly the same really in Surrey and Sussex. As you can see, this is a 2-week rule referral over the last 18 months or so. 2019 is just to the left of the line. We can see that normally just running a bit below the 2,500 with a summer dip, but then with the COVID lockdown in March, a significant drop in absolute numbers down to just over the 1,000. But again, as reflected in Thames Valley, since the end of last summer, we've seen a really steady increase, significantly more perhaps than would have been expected, making up for that shortfall almost that was caused by the significant drop in March and April from referrals from GPs. Next slide, please. And this just shows it in a slightly different way, just percentages rather than absolute. We can see that April 2020 to 19, we had that 50% drop, that real cliff edge. But then since August, funny enough, where we normally saw a dip, we've seen about 120% of the volumes for equivalent months in 2019, which has really made up for that shortfall, but obviously also put pressure on a lot of our secondary care colleagues in busy clinics, and almost making up for that drop in April. Next slide, please. And here we can see breast has actually recovered the best in terms of all tumour groups, really to baseline. Looking at it from March to December levels, normally in 2019 you get about just under 22K in terms of volume of referrals, and nearly back up to that at 96%. Considerably more, considering everything that's been happening than you might have expected, and we can see that compared to tumour groups like lung and prostate, breast has really improved in terms of referral rates. So that's where we are in Surrey and Sussex, very much reflective in Thames Valley, and probably what you're seeing in primary care. That's all from me, Anna. Thanks very much. I'll hand back to you.
Yeah, thank you, Alex. And I think those are interesting sort of graphs, really. And I'd be very keen to understand in the chat box if people want to put any comments about referrals and why they see that there's been a bit of an increase over baseline. I think health anxiety is probably one of the things, but I'd be very interested to hear from people with their experiences. So we now come on to the NICE guidance and the importance of breast examination. And I'm delighted really today to have two very skilled individuals who've done a lot of work on some of the pathways. Anushka Chaudhry, who's the breast consultant and Thames Valley Cancer Alliance clinical lead, and Charles Zammit, who's a consultant breast and endocrine surgeon at the Surrey and Sussex area. So I'll hand you over, Anushka and Charles.
Hello, it's Charles Zammit here. Thank you so much for organizing this and inviting us to participate. It's great to collaborate as alliances as well. So this talk is being shared with Anushka, so I'll be focusing mainly on the referral guidance. As you can see here, this is the latest that I could find with reference to the breast referral from NICE, and obviously similar ones from Macmillan. So when it comes to urgent referral for breast cancer, as you can see, these are the criteria, and I'll be breaking this down bit by bit to explain why it's been done so. As you know, when it comes to breast referrals, we've got the urgent 2-week referral and the non-urgent 2-week referral as well, which doesn't really make that much sense when it comes to it. But I'll just focus on the urgent cancer cases and what it all means. So next slide, please. So this is something which we always need to remember. When you read the Daily Mail, I always quote the Daily Mail because they somehow pick on breast cancer, particularly celebrities who have this. And they always start with the same sentence saying, the epidemic of breast cancer, which affects 1 in 10 ladies and so on and so forth. So the 1 in 10 comes as a ratio if a lady lives up to 85 and is of Caucasian origin. That's what that means. But unfortunately, these celebrities, there's 2 examples here. The latest one is on our left from Girls Aloud. They're in their 30s, they're famous, they're young. But the risk of breast cancer increases with age. It's not a disease of younger ladies. So it's exceptional to have the younger ladies with breast cancer, though it does happen. So I just wanted to clarify that. And this is why age is important. So if you see a young lady in her 20s, it is extremely unlikely that she has breast cancer. And, you know, in primary care, when you see these ladies, it's worth reassuring them that the vast majority of ladies that we see do not have breast cancer. So, for example, in Brighton, we get between 5,000, 6,000 ladies a year to be seen, and we pick up 300 cancers in a year. So most of the patients that I see in clinic, that we see in clinic, do not actually have breast cancer. And it's worth remembering that to reassure your patients that the vast majority, although investigate them, we don't find anything wrong with them. So that's quite reassuring for them as well. Next slide, please. So I'm breaking down the referral pattern. Nipple discharge seems to be highlighted quite often, but the real fact is that it's less than 5% of breast cancers that actually present with nipple discharge. And when we get ladies with bloody discharge, literally macroscopic blood in the nipple discharge, 50% of that is just the benign papilloma. So again, if you see a lady with bloody discharge, again, it's worth emphasizing the fact that she needs to be referred, she needs to be investigated. But again, it's all part of preparing the patient and reassuring them in the right way that most of the time it's not cancer, but it still needs investigations. We see a lot of ladies with different forms of discharge, toothpaste consistency, green, brown, any color other than red, we tend not to worry about. If it's clear, it can still have microscopic blood. So a simple trick would be to get your dipsticks and go to the hemoglobin bit and touch the bit, which is the hemoglobin bit, onto the discharge if the patient can express it, to see if it has blood. And if obviously it has blood, then that's when we need to take things further. Importantly, with discharge, it needs to be spontaneous rather than the patient pressing hard on the nipple to check themselves. So part of the breast awareness, part of the self-examination, the patient can examine around the nipple bud, but not to compress it. We don't want to see ladies pressing their nipple bud, creating even more duct ectasia, more duct inflammation, possibly infections. Next slide, please. Axillary lumps. In Brighton, I don't know elsewhere, GPs do not have access to axillary ultrasound for lumps in the axilla. And the simple reason is that we want to provide you with a good service of us examining the axilla for you, examining the breast just in case the swelling in the axilla is related to breast pathology. We see a lot of ladies with excessive breast tissue. The breast naturally has a tail going up to the axilla to a variable degree. It usually is asymmetrical. It usually presents itself more clearly in ladies who are breastfeeding or pregnant, obviously. And these don't need imaging at all. They just need reassurance that this is simply just the breast tail. And obviously, if they gain weight, it's part of the body mass, just like the breasts gain fat along with body weight, the axilla does the same. Obviously, it could be a lipoma. And again, we need to check if it's part of multiple lipomatosis, just in case it's part of Dercum's disease, which can be associated with diabetes. It could be a blocked sebaceous cyst, usually secondary to shaving, unknowingly scratching yourself. And what gives it away is that the skin is fixed to the lump, very superficial, and sometimes you can see a punctum. Lymph nodes. Now, again, shaving is the main culprit, or gardening, or cat scratches. Importantly, we need to ask now, did you have a COVID injection in the last week or so? Or a bit longer, because we're getting a lot of reactive lymphadenopathy in the site of the injection of the COVID. And especially in ladies who had previous breast cancer, for example, and they get injected on the same side as the operation for their surgery, it might create confusion, particularly when it comes to physical examination and imaging. So it's important to tell patients not to have the COVID injection on the site of surgery, because whoever gives the injection, all they ask them is, are you right-handed or left-handed, and not necessarily anything else. So when it comes to presentation of a lymph node in the breast, of a lymph node in the axilla associated with breast cancer, and there's nothing to feel or see in the breast, it's a very rare presentation. Obviously, if this lymph node in the axilla is part of generalized lymphadenopathy, that's obviously something that you're all aware of that needs systemic investigations as well, as it could be part of lymphoma or some other immunological disorder. So that's from the axilla point of view. Next slide, please. Nipple changes. Many ladies have nipple inversion to some degree, unilateral or bilateral. It's of no consequence. The nipple areolar complex is like a roundabout with about 20 major ducts leading to it. And if one or two ducts is a bit shorter, particularly as ladies in menopause, the breasts tend to get more fatty, and hence the droopiness and hence the movement of the breast further down, that you can get nipple inversion as a physiological change as well. So we need to be aware whether it's a recent change or a chronic change. So obviously we need to make sure that there's no underlying lump, and essentially nipple inversion, in 95% of cases, there is an associated lump beneath that. So that's something to be aware of. Paget's is quite difficult. Paget's on its own is quite rare. 50% have an underlying lump. Personally, I prefer if you do not start off with hydrocortisone or steroid creams, unless the patient is known to have eczema or psoriasis elsewhere. So if it's a one-off, if it's a new event of scaliness around the nipple, there's no evidence of eczema, please do refer them rather than empirically start them on steroids and then see what happens. Eczema can be exactly the same as Paget's, usually bilateral, and obviously there might be other skin changes. So that's my view about that. I hope that's reassuring for you. Next slide, please. I know your college has been encouraging you because of COVID to do virtual clinics. Obviously, in breast, this is next to impossible, other than breast pain. And I think we've got another speaker, Susan Halliday, is going to talk about breast pain. But importantly, next slide, please, and this is the last slide, there's nothing 100%. So again, just like in the axilla, we do not allow access to mammography to GPs because we want to help you. We want to make sure that we've examined the patient fully, and there's limitations to mammography, particularly the younger you are. And you can see mammography increases in sensitivity as ladies get older. Some ladies have dense breasts, some ladies are on HRT, which makes it even worse. So having a normal mammogram does not guarantee that there's nothing else going on in the breast. And this is why we try and help you with management of these patients with a good service rather than sending them off to mammography and then sending them back to us. I hope you found that helpful. Remember, triple assessment, history and physical examination, which virtual clinics try to remove the physical examination bit, but we need to do all three things for us to diagnose breast cancer, which we managed to do in about 95% of cases. Thank you.
Thank you, Charles. That's really useful, and it's great to see that you're keeping up with pop culture and Girls Aloud. Really great. Anushka, examining the breast. We're running slightly short of time, so over to you.
Thank you so much. So I'm not trying to teach you to suck eggs, if you can go to the next slide, but I think it is hugely important, the relevance of doing a proper breast examination, because we all know that in medical school you spend less than a week in a breast placement, some if at all, yet you are the clinicians who have to see the worried well and the truly worried people in the community. And also examining the breast appropriately is really important for your documentation medical legally. Now, you may see in our letters these descriptions of P1, P2, what does it all mean? And essentially it is as it says on the tin. We tend to document whether a breast feels benign by putting a P2 all the way up to malignant with a P5. And please do communicate back if you think that something that we're saying in our letters is confusing to you, because otherwise we won't learn from each other. Next slide, please. The important thing to know is that 13% of women with a palpable breast mass and a diagnosis of cancer actually had a normal mammogram within the preceding year. So our policy is if somebody has had a mammogram within more than 6 months from the time they presented, we do tend to repeat it. Otherwise, we only repeat it in clinic if there's a real clinical suspicion. And again, without going through the whole table in front of you, it's just about the terms that we use to document. And the importance of this is if we are ever able to get to a stage where breast clinicians are able to triage using the nice guidance from the referral forms, especially at times of increased referral, then using terms like this lets us know whether you believe this is something to be really worried about, or it's more likely to be benign. And by using this kind of language, we're documenting to each other so we can have a kind of mutual understanding, because we do appreciate that you are only given one referral form and 1 2-week method of referral into the hospital. So it's very difficult for you as well to just say, look, I'm not really worried about it, I need to be seen. Next slide, thank you. So Charles has already gone through some of the features of the nipple. I won't focus on specificities, but part of when I see a patient in clinic, I feel like the history being the most important part, and then the examination is going to really give me an idea before I've even put my, got any imaging. Of course, we have the benefit of having imaging on patients if we want to before they come to see us in clinic. The key thing I want to focus on here, honestly, is asymmetry, because a lot of women with symptoms that we're going to be discussing further on, such as breast pain, they specifically have different size breasts. Now, that's a completely normal phenomenon. I reassure them of that. And it's often that the pain tends to be more on the larger side than the other side. And I simply explain it to women and use terms like they're sisters, not twins. So don't worry, they're not supposed to be identical. They behave very differently, in fact. And there happens to be more glandular or more sensitive tissue on your slightly larger side than your smaller side. And as soon as people know what's normal for them, they feel hugely reassured. Next slide, thank you. So once you've had the patient sitting at the end of the bed, exposed appropriately, and you've done your inspection, ask them to put their hands on their hips and squeeze in. If a lump is attached to the muscle, it may become more prominent and easy to see. You can also ask them to lean forward, either with their hands on their hips or above their head. Now, women with anything larger than a C cup, raising their hands above the head isn't going to be the most useful exercise. So I would always recommend just gently lifting up the breast as well to see if you can see any puckering, scars or ulceration underneath the breast. It's amazing how many women with larger breasts can't actually see or don't look under their breasts. And sometimes there can be a fungating tumour sitting there. Next slide, thank you. So it doesn't matter how you do it. My personal preference is using the lines method, because we must remember the breast tissue extends from just below the clavicle to the 6th rib. So actually it's not just where we all think the breast mound is. And I feel it's really important also to tell my patients that whilst I'm examining them, having a bit of a chat. And this allows you to include all the potential breast tissue in your examination using the pads and the flats of your fingers rather than dipping your fingers in and poking them. Textbooks will say to give the nipple a squeeze. I don't do that. I ask the patient to do it for me, because you just don't know how sensitive it is. And we must always be aware of how intimate it is meeting someone for the first time. And within 5 minutes, we're face to face with them with their top off on the bed. And they feel even more weird now because they're wearing a mask while we're exposing them and examining their breath. Next slide. So examining the lymph nodes, I always tell people to take the patient's arm as if you're shaking their hand. That's how you remember. Ask them to relax their arm completely, and then press the fat of the axilla tissue towards the ribs, because only by pressing that fatty tissue against something solid will we be able to determine whether there are any enlarged lymph nodes. I also take this opportunity, especially in breast pain patients, to ascertain if there's tenderness along the lateral border of pectoralis, and also on the back of the axilla, where the latissimus dorsi tendon can be quite tender, and that will allow you to know whether there's a musculoskeletal element to this. Taking your hand down the chest wall a little bit laterally as well might see if there's any tenderness on the serratus muscle. And I do say to patients, if they're specifically tender here and have come with breast pain, it's very reassuring, because pain that comes from the muscle can radiate into the breast, whereas true breast pain doesn't tend to radiate out to muscles. 30% of women with palpable nodes will have no breast abnormality. And we've already talked about the COVID vaccine, but also to remember that 40% of women with normal feeling nodes actually have metastases. Thank you. Next slide.
Anushka, before you go on, there's a question about, do you have any tips for examining larger breasts?
Yes, absolutely. So rather than having the patient, I always have the bed at 45 degrees, and rather than having the patient just lying on their back, ask them to tip their hips so they're lying slightly towards you. That brings the breast to kind of lie on top of them, so you have a flat base to work with. And sometimes it's okay also to ask the patient to help you, but just by tipping their hips towards you, it can be a bit easier to envelop and encompass all of the breast that you need to examine.
Thank you.
Okay, not at all. Now, again, Charles has gone through a lot, but there are some things that are really simple, and you can imagine, as Anna has said, how anxious women are when they come to clinic. Montgomery's tubercles, which is the last picture on the right, are very typical sebaceous glands under the areola. Some women think that they've got new changes, but they can appear at any time through life. Encourage them not to squeeze them. Tell them they can get bigger with hormone changes and with pregnancy, but they're nothing to worry about. With things that are sebaceous cysts, now I know that, again, we have the benefit of scan, but often just document, can you see a punctum? Is this really necessary to be referred just because it happens to be on the breast, or could it just be a sebaceous cyst? And then the accessory breast tissue, again, is something that women think is a true lump. I always ask about weight changes in the weeks before they come to clinic, because they go, yeah, I put on some COVID weight. Well, have you always had a bit of a swelling in the armpit? Yeah, probably a little bit. Well, this is your accessory breast tissue that's gotten a little bit bigger. It can hurt with your periods, and it's nothing to be worried about. Things, again, that we get referred in on a 2-week wait. And again, I appreciate you don't have other means of referring them. Are cosmetic breast consultations. They shouldn't be coming in. Breast reduction referrals without prior CCG approval, because this is a 15 or 10-minute appointment. We haven't got the time to discuss such patients in a clinic like that. Women who want screening mammograms, they don't come to these kind of clinics. A lump that has now disappeared because women say, well, I was just told to come anyway, just in case. They don't need to come. I say to them, cancers don't disappear, so you don't need to come if your lump's gone away. And then we're going on to go to talk about breast pain and gynecomastia. Next slide. This is actually the last one, but for me is the most important one, because it represents about 1% of breast cancers and is very difficult. And I also think medico-legally for you, very difficult. A woman presenting with inflammatory breast cancer is like a simple mastitis. Now, it's not to say that everybody with a red breast should be referred into the breast clinic straight away, but please make sure that you're documenting the intention to review them once they've had a course of antibiotics, because inflammatory breast cancer does not get better. Yet these patients have a high presence of metastases at first presentation, and they often are a cause of delayed referral to breast clinics. Happy to focus on that another time, but I understand we're time pressured, so thank you very much.
Thank you, Anushka. Just a quick comment from you. There's a comment here saying breast reduction referrals need assessment of amount of tissue to be removed, though. What are your thoughts?
Well, I would say that we don't necessarily have to assess the amount of tissue. A patient requesting a breast reduction will tend to be large-breasted. I think it's something that's very difficult because we only have a rapid access clinic to see them in, and we do need to work together to find a different way. If we have a simple letter coming into the clinic, I personally and my colleagues ask to see them on a follow-up clinic, which is more appropriate, rather than a rapid access. So I think we need to work together to fight against the ways that we have to refer patients in on 2-week wait referral forms.
Fantastic. Thank you, Anushka. Again, both speakers, thank you very much for that. Breasts obviously are in men as well. So over to the next speaker, gynecomastia, an overview and approach in primary care. Mr. Simon Hawkins, who's a consultant oncoplastic breast surgeon. Thank you, Simon. Over to you.
Yes, thank you very much. Can you see me? I've switched my camera on, but my picture doesn't seem to have come up yet.
No, we can't see you, Simon, but we can see the slides.
You can see the slides. Okay, that's the important thing. Okay, thank you very much, everybody, for inviting me to speak today. My name is Simon Hawkins. As it's been said, I'm a consultant breast surgeon here in Swindon. I've been asked to talk to you about gynecomastia, with a particular emphasis on how to approach it in a primary care setting. So what I really want to cover in these 10 minutes is what is gynecomastia, how we can differentiate gynecomastia from a potential male breast cancer, and it's important that we're aware of the common causes of gynecomastia and who does and doesn't need referral. And I'm going to try and give you a framework that may be useful that you can use, hopefully, in a primary care setting. And if we have time, hopefully we can go on and talk a little bit more about how we maybe manage gynecomastia in a secondary care setting in the breast unit. Next slide, please. So gynecomastia, what is gynecomastia? Well, essentially, it's hyperplasia of the glandular tissue in the male breast, which is a benign process, which is driven by often quite subtle alterations in the difference and balance between estrogen and testosterone in men. And this may not often be measurable. It may just be that it's an imbalance for that individual, which isn't actually detectable in a blood test. And during that developmental phase of gynecomastia, it often can be quite painful. So for the first few months, we know that the patients will often present with pain rather than a lump. But we know also that that pain often tends to burn out as the gynecomastia becomes more established and fibrotic. And what you tend to end up with is a situation where you have a man with either a unilateral or a bilateral, often rubbery, benign feeling lump behind the nipple. So that's what gynecomastia is. Very different from pseudo-gynecomastia, which it's important to be aware of as well, which is a sort of classic, for want of a better term, man boobs, where you have bilateral male breast enlargement due to fat deposition. That's extremely common, obviously, and doesn't require any further investigation or treatment. Next slide. So I suppose that the first question we need to ask ourselves when we're presented with a patient who's presented with a male breast lump is this a male breast cancer or a gynecomastia? Well, the first thing to be aware of is that gynecomastia is extremely common. If you start going looking for it, you'll find minor degrees of gynecomastia in large proportions of males over the age of 70, whereas male breast cancer is uncommon, but obviously it's a diagnosis that none of us want to miss, and it's an important diagnosis. So approximately 0.5% of all breast cancer diagnoses occur in men in the UK, and we as a nation see about 400 new cases each year. At Great Western, we may see 2 or 3 cases a year. And it's important as well to be aware that these diagnoses of male breast cancer are extremely rare in the under 50 age group. But we do understand, particularly with current cultures and the messages coming down from on high, that concern regarding missing male breast cancer may be a major driving factor in whether or not these patients need to be referred. Next slide. So it's important when we thinking about who to refer and who not to refer, that we understand the causes of gynecomastia. And the most common cause rather of gynecomastia is physiological causes. So we know that we will see gynecomastia in neonates due to placental estrogen transfer. We know that gynecomastia is also extremely common in pubertal males, and that's generally because we find in puberty estrogen production commences earlier than testosterone production. So a large portion of pubertal males will develop a degree of gynecomastia. 90% of that will regress post-puberty. And very importantly, we also see a large proportion of gynecomastia in what we call senile gynecomastia, which is in elderly males as part of a natural decline in their testosterone versus their estrogen production as they get older. And if you go looking for it in the over 70 age group, you may find a degree of gynecomastia that's asymptomatic to an extent in up to 65% of males. So it's extremely common. Drug-induced gynecomastia, again, a very important cause of gynecomastia. Approximately 10 to 20% of all gynecomastia has a drug-induced cause, and these tend to be drugs that are either estrogen-containing or in some way block or inhibit the production of androgens, particularly the ones you'll hear talked about commonly are things like prostate cancer treatments, spironolactone, finasteride. And recreational drugs are also very important in this: marijuana, amphetamines, heroin, methadone. Next slide. So the secondary causes of gynecomastia, which is pathologies, underlying pathological conditions which may be causing gynecomastia, it's important to be aware of, because these are the cases where we can often detect these with targeted use of screening blood tests alongside clinical assessment. And in this situation, we're talking about adrenal and testicular tumours, which particularly may produce estrogen, androgens, or beta-HCG or alpha-fetoprotein. Systemic illnesses such as cirrhosis, renal failure, obesity, and HIV, and of course endocrine problems, the main number one of which is likely to be primary hypogonadism, which causes about 10% of all gynecomastia cases, but also other things such as secondary hypogonadism and thyrotoxicosis. But even knowing all this, we know that a large proportion of gynecomastia cases may have no obvious underlying cause. Okay, next slide. So what I want to go through, if I may, is a framework on which you may be able to approach these patients to know when to refer and when you maybe don't need to refer and can reassure the patient. So it's important, obviously, to take a history. And it's really important in these situations that you include a full medication history, recreational drug use and alcohol consumption. And you're now supported when it comes to clinical examination. The national guidance from the Association of Breast Surgeons is that in the primary care, you only need to be examining the chest wall bilaterally. You don't need to be examining the axilla, and you particularly don't need to be examining the patient's testicles unless you have a particular concern in the primary setting. So focus on the chest wall examination. Next slide, please. So the first question I suppose we need to ask ourselves when we come into the assessment phase is, am I concerned regarding a male breast cancer? So obviously, if you have a high clinical suspicion, then these are the patients that we would encourage you to refer. But features that you should be looking out for that should alert concern regarding possible male breast cancer would include things such as males over the age of 50, particularly with unilateral firm or hard subareolar lumps with or without nipple discharge, particularly with skin change, skin tethering, ulceration, and bloody nipple discharge. And we would urge you to refer these patients on a fast-track 208 cancer pathway. However, most patients won't fit in that scenario. And if none of those are appropriate, next slide, please, then the next question I would suggest you may ask is this pseudo-gynecomastia, or is this true gynecomastia? Or is it something else? If it's pseudo-gynecomastia, then there's no need for any further investigation. The patient can be reassured. If it's true gynecomastia, then some of these patients may need further investigations. Others may be appropriately reassured at that point. So there's certainly no need for further investigation or referral for a group of patients that include adolescents with physiological gynecomastia, remembering that 90% of these will settle as they complete puberty, and elderly men with senile gynecomastia where their testosterone levels are naturally reducing and they've got gynecomastia as a result of that, or men with an obvious drug-related cause. And of course, in these patients, it may be reasonable to consider if alternative medications may be appropriate. Often they're very important treatments though, and they have to be continued. Next slide. So patients that we would suggest do require further investigation in primary care include those patients that may have particularly rapid onset or enlargement of their gynecomastia, recent onset of gynecomastia in men over the age of 20, persistent painful gynecomastia over 12 months duration, very, very large volume gynecomastia, and possibly persistent symptoms in adolescents over 24 months only. Okay, next slide. So how would we investigate?
Can I just interrupt you there for a second?
Yeah, sure.
Sorry. I think Lamis was asking a question. He put his hand up.
Yes, please. Can you hear me?
Yeah.
Yes, I can.
Okay, great. Sorry, you mentioned earlier that it would resolve, the gynecomastia would resolve at the end of puberty. But I've had a couple of, teenage boys who are quite body conscious about it. So roughly what kind of age am I looking at to reassure them that it should have cleared up by?
So I think over the age of 20 is what the guidance is suggesting is an appropriate age.
Okay, and if for example their father has got gynecomastia as well, is there less chance that this is actually going to resolve and more that it's a permanent thing?
No, it shouldn't be a genetically inherited condition. So no, it shouldn't really be a consideration from one generation to the next.
Okay, lovely. Thank you so much.
Okay, no problem.
Thanks, Simon. Carry on.
Yeah, so the patients, as we saw there, those patients that we think do require further investigation, what investigations are appropriate? Well, so if we're doing targeted blood tests in these patients, we may pick up some of those underlying conditions that may be causing their gynecomastia. So as a baseline in primary care, we would suggest for those patients that you're not reassuring because they've got senile gynecomastia or pubertal gynecomastia, that they should have a fasting testosterone, thyroid function test, liver function tests, alpha fetoprotein, beta HCG, and gonadotrophin tests. Okay, and if on those results the testosterone levels come back abnormal, it may also be appropriate to go on and check their LH, FSH, albumin, estradiol, and prolactin. And if the beta HCG or AFP comes back high, then it would also be suggested that you could go on to arrange a testicular ultrasound. Okay, so patients who have then, through those screening tests, have either an abnormal endocrine cause identified, may appropriately then be referred on to a medical endocrinology clinic because the gynecomastia is a secondary cause of that. Equally, patients with abnormal beta HCGs or AFPs or abnormal testicular ultrasounds should be urgently referred to urology clinics. But patients who have not now been reassured and still have problematic gynecomastia or unilateral cases without an identified cause. And also those patients where you feel there is a potential male breast cancer. These are the patients that can be appropriately referred to a breast clinic. And obviously our function is to a large extent to exclude male breast cancer. We have full triple assessments available in our breast clinics. We don't always image all patients who come in with gynecomastia. Generally speaking, we will only image if there's a particular clinical concern, as Anushka was outlining earlier, of P3 and above, and we may use a combination of mammogram or ultrasound scan depending upon the age of the patient. And we would only use biopsy if we felt that there was a concern either clinically or on imaging. Remembering that fundamentally gynecomastia is a benign condition, so the vast majority of these patients are going to be reassured with appropriate forward referral for those patients that are found to have another underlying condition causing their gynecomastia. So just briefly, I'm going to mention what we may also be able to offer these patients in secondary care. Well, drug treatments are off license in most cases. So tamoxifen and anastrozole, the estrogen blocking agents or preventative agents are off license. So we don't use them very often. And they tend to be most effectively used in patients who have had recent onset of gynecomastia. Once gynecomastia is established and has become fibrotic, then they tend not to regress with these treatments. And in established cases, surgery may be the best option to actually physically remove the lump. But we cannot overemphasize enough that surgery for gynecomastia as a benign condition has a significant cosmetic element to it. It's not normally funded. Usually it has to be pursued in the private sector unless you can get successful exceptional funding approval, which you all know is becoming more difficult. And with these patients, patient consent and patient selection is absolutely key. It's a very highly litigious area of breast surgical practice. And with patients with poorly selected cases, particularly where you have patients with large volume gynecomastia with skin excess, often less satisfaction levels with the outcomes of surgery can be very poor if you're not selecting your patients very, very carefully. Okay, thank you.
That's really useful, Simon, and there's been a bit of chat about a variety of aspects of gynecomastia, which Anushka has answered very well. But thank you, Simon. That was really useful and really clear.
Thank you.
Okay, well, time with pressure is a problem today. We'll quickly go on to breast pain. I'm delighted to have Gail McLean with us, consultant oncoplastic breast surgeon. Over to you from Oxford.
Great, thank you, and thank you for the invitation. Yes, my name's Gail McLean. I'm one of the surgeons working in Oxford, and I'd like to just run through some things regarding breast pain. Next slide, please. So first of all, you need to define what you mean by mastalgia. Is that cyclical or non-cyclical? Cyclical is usually pretty easy to establish by taking a history from the patient. It should be worse premenstrually and relieved by menstruation, but pattern is not seen in non-cyclical. Is this true breast pain? Is the pain truly originating in the breast, or is it referred pain? Referred pain is most often costochondritis. You can elicit the symptoms the patients are describing by getting them to lie slightly on their side towards you with the breast coming off the chest wall and eliciting pain by pressing on the lateral chest wall where there'll be inflammation of the costo cartilage there. And this can often last for quite a few months because it's usually viral in origin. Next slide, please. So I just wanted to share with you some of our referrals in last year to show you that the referrals in age, and just to say that all of you working in primary care are doing a great job in triaging. If you look at, these are the 2-week wait referrals, so these are suspected cancers. So the red shows those patients who are actually eventually diagnosed with a cancer, and as you can see in the under 30 and also in the under 40, very small numbers. And again, these referrals are appropriately not being sent through as urgent cancer referrals. So there's very good triaging from our GP colleagues, of which we're thankful. Next slide. So, but regarding breast pain referrals, we have seen that some months up to 25% of our referrals, looking at all ages, and to the breast clinic have pain as the only symptom. And this is significantly contributing to our current figures which I received this morning showing that trying to meet our 2-week weight target, we're not meeting that. We're now at 24 days in which we're offering patients appointments because we're being so swamped with referrals. The vast majority of the breast pain referrals are in the under 40. These are with only breast pain as the symptom, no lump. They're in the under 40 age group. And the Association of Breast Surgery recently has put in writing that breast pain alone is not a sign of cancer. That's something that we have all recognised in the breast surgery community, but it's been very reassuring that our professional body has now put that in writing to guide referrals. Next slide, please. Coming back to some of our figures from last year, if you look at the referrals for symptomatic, so these are patients that are referred in that are thought not to have cancer. Again, great triaging in primary care, where very small numbers of cancers under 40, and most of these referrals are referred in as symptomatic, not suspicious of cancer, but the numbers are still huge. We have 6,000 referrals per year, and as I've said, sometimes up to 25% of them can be pain only. Next slide, please. So how do we manage breast pain? Well, reassurance is by far the mainstay of treatment. One of the previous speakers mentioned that cancer is very rare in the under 30 group, so that can be very reassuring to inform patients of that. Of patients who are actually referred with pain only, less than 2% will eventually have a diagnosis of cancer, and that is normally because these are patients who are in the over 40 age group, therefore having a mammogram, and it's an incidental finding that would have shown up if they were in the screening age group. It would have shown up at their next screening mammogram. So pain only is very rarely associated with a diagnosis of cancer. A 3-month diary can be very useful to inform yourselves, but also to inform the patient, to show that there sometimes is a cyclical pattern which maybe hasn't been picked up before. There are some websites that provide this, that patients can put in their own symptoms into website for particularly for younger patients who are more sort of app aware and would like to use that facility. A supportive bra cannot be emphasized enough. A well-fitting supportive bra, the patient should be able to remove the straps off their shoulders and nothing should move. The support should really be coming from the waistband around the waist. So that's very encouraging, to encourage patients to have a supportive bra and go for a bra fitting if necessary. Simple analgesia, non-steroidals in particular, to help with pain, and topical ibuprofen gel can also be very useful. Using a soft non-wired bra at night, and there's no evidence to say that wearing a wired bra increases pain, but in terms of sleeping, it's usually more comfortable to sleep in a soft non-wired bra. Next slide, please. So if you look on the NICE website, the following are not routinely recommended in the management of breast pain. Stopping or changing other medication, including the combined oral contraceptive pill, is not recommended. There's no evidence to show that that can significantly help. Prescribing progesterone only contraceptives for breast pain, again, limited evidence. Changing the amount of fat in your diet or caffeine in the diet. The Daily Mail was mentioned earlier in this webinar, and that has come up quite often in the Daily Mail, but there is no evidence for that. Evening primrose oil is not routinely recommended by NICE. I'll come back to that in a minute. Antibiotics, diuretics, vitamin E, danuzol and bromocriptine, again, not routinely recommended for the management of breast pain. Next slide, please. So the evidence for using progesterone only is very weak and actually showing that it's no better than the placebo at treating breast pain. I'm going to come up with a slide in a minute that gives you the some references to look at. Next slide, please. So in terms of evening primrose oil, which has and still is recommended, there is evidence from systemic review of 4 RCTs to show that evening primrose oil is no more effective than placebo at reducing the frequency and severity of breast pain. And there's a lack of good quality to support its use. So nearly a decade ago, the license for this was withdrawn by the UK Medicines Control Agency. Having said that, it won't do any harm as long as patients are not taking epileptic medication or not trying to get pregnant. There is no harm in patients trying a course of that as long as they're aware that any improvement is probably going to be due to a placebo effect. Next slide, please.
Gail, can I interrupt you there for a second? Someone's asked the question that if pain is cyclical, would it not be better to start POPs to see if patient doesn't have a cycle and help the pain?
So although these the list of things that I said that NICE was not routinely recommended, it doesn't mean that you can't use them in individual patients. Obviously, we tailor our management to the individual patient. But what I would say is that go with the simple things first to see if they work. So the simple analgesias, the bras, and all the other measures that I suggested. Once these these things that usually work, if they haven't worked, then you might be at a point where you would want to suggest that. But I wouldn't start with that.
That's really useful, Gail. And can I also say that advice and guidance is a very useful process whereby rather than referring, you can ask for advice and guidance. So would you agree with that, Gail, as well?
Oh yeah, absolutely. I mean, there's a movement in many trusts to set up a email helpline. We haven't established that yet in Oxford, but if your local trust has that, that might be something that you want to run by them. I often get a lot of, I'm clinical lead, and I often get a lot of GPs emailing in and saying, I really don't feel this is appropriate for a referral. What do you think? And that can be very helpful, going both ways, both from us, reducing our number of referrals, but also for the GPs help.
Lovely, thank you. Go on, carry on for sources.
So here's some sources of information with the NICE guidance, which I think is excellent. Actually, I would really refer you to that. And there's also from America, there's a nice summary of risk factors there. Next slide, please. So just in summary, the key points are the big take-home message is that breast pain alone is not a sign of cancer. And when it does result in a cancer diagnosis, usually in the older age group, it's often an incidental finding from opportunistic screening when we do a mammogram in patients over 40 coming to clinic. Reassurance is absolutely the mainstay of treatment. Simple analgesia, topical ibuprofen, supportive bra, evening primrose oil, sometimes recommended. You have to use it for at least 3 months before it can start to work sometimes. And as long as you're honest with the patient and say, you know, this might just be a placebo effect, but it won't do you any harm, it's worth a try. And I would only consider referral to breast clinic once you've tried all the conservative management measures after about 3 months.
Thank you so much, Gail. That's really, really useful and really practical advice that I've learned a lot about bras, cup size, and all of that. So thank you so much for that. Time is really moving on. So we're going to go on to the breast symptomatic referral resource suite. And can I please ask, I'm so sorry, but we're going to have to rush through this. So I'll hand you over to Alex and Suzanne, please.
Hi, Ananta. Yeah, I'll do my best. It's Alex Mency-Barrett. I'm a GP in Brighton. And because this is aimed at primary care, Susie's asked me to speak, although I have to admit that it's almost exclusively Susie's work and also that of Charles. But I think this work that we did locally is a good example of joint working. So next slide. So as Gail has just said, we know, and we've always known, that breast pain is not a high-risk symptom, and it's not a never has been an NG12 referral trigger. But I think in primary care there's been some sort of confusion between the rule or the guideline that anything that's referred symptomatically is treated in effect as a 2-week rule, has sort of become confused in our minds with the sense that any symptom needs to be referred, which clearly isn't the case. And as Gail has said, breast pain in the absence of any other findings is a very low risk. But it is unfortunately, again, as Gail has said, a very common cause for referral, and a retrospective audit at BSUH in June last year, or now the year before last, showed 28%. I think Yale had 25%. So a significant number of people are referred for breast pain alone. And in that very small audit, no cancers were diagnosed. And if the next slide, please. A retrospective audit of over 5 years of nearly 700 people who were referred, who had imaging for P2, including breast pain, showed actually an even lower pickup rate of cancers than the less than 2% that Gail referred to. And I think the next slide shows that I think that only 3 were picked up out of that cohort, which is, I think, even less than a background population. Next slide. So yes, three cancers. One of them had contralateral DCIS, one had previous cancer, and one had normal breasts on imaging, but grossly abnormal axilla. So I think we in primary care can be confident that breast pain alone is not significantly associated with breast cancer, and therefore, combined with, as I say, the sense that not all symptoms need to be referred, we undertook some work locally in Brighton to try and give primary care the resources and the confidence to try and manage these low-risk patients themselves. And next slide, please. Yeah, I think certainly specialist colleagues and probably some GPs are aware of a pre-existing Nottingham pathway where there are some links in the form giving people advice as to how to manage conservatively and asking people not to refer until they've tried these. Although, of course, I don't think any service will turn away referrals if patients are not able to be reassured and convinced in-house. The Nottingham pathway included a link to breastcancercare.org, which had some advice, including to use evening primrose oil. So in Brighton, we felt uneasy about that. And we next slide, please. Our first forms had different links linking to NICE CKS clinical guideline and clinical knowledge summary links but similar how to manage these people in primary care before referring on. And we also put some links for management of bilateral eczema, and also for men we put some links and guidance around gynecomastia, which links into the presentation we had earlier. So initially we had 2 forms, a male and a female form, but earlier this year we joined them, next slide please, to a gender inclusive referral form. Where we're using the terms assigned male at birth and assigned female at birth, because obviously, certainly in Brighton anyway, we've got a significant number of people who've undergone transition, and it clearly makes a big difference when it comes to a breast referral to know what's going on. So that's something that we're very proud of in Brighton, having engaged with our community. Next slide. So admittedly, this is against the backdrop of COVID. You can see that our breast pain referral rates have dropped over the last, over the main part of last year, from an average of 25% to sort of between 10 and 15%. And next slide. The reassuring thing is that that hasn't resulted in any reduction in cancers being detected, which we would expect, since we wouldn't expect there to be cancers in this group. And next slide. Yeah, so there's a summary. I hope I get full marks for doing a 10-minute presentation in 6 minutes or even less, and apologies if that means I've missed anything, but thanks very much.
Oh, fantastic. Alex, you've been brilliant, so thank you so much. I'm going to mute you, Alex, sorry, because of feedback. I think that's really useful. I think we've covered a huge amount today, and the speakers have been excellent. Really a lot of learning there. We will be sending the slides out to everyone as a link, so please don't worry, you will get this information again. One of the key things is that we would like to hear some feedback from today's session. There will be a link in the chat box and certainly might be emailed out to you as well. If you could please fill this in, it'll take just a few minutes. Really useful. I know today's been a bit of a rush. Thank you all very much for your questions, and thank you for the specialists who fed back with the questions and answers interactively and in the chat box. Any final few questions from anyone? Any final 30 seconds? Really grateful for all the speakers today for giving up some time and preparing for it. Here are some sort of contact details if you have any questions or any information you need. Hannah has been fantastic putting together this webinar together, and Suzanne for Surrey and Sussex as well. But thank you all very, very much, and thank you for the speakers again. I think it's been really useful, so please do take care and keep well. 1 minute over time, but thank you all very much. Be safe.